I would like to welcome everyone to the Resnik Implant Institute Grand Rounds webinar. We're excited that you have joined us tonight, and this is going to be a very informal, great learning experience for you. These webinar sessions are a perfect supplement for our online and our in-person curriculum. Before we get started, I'd like to introduce Hussein Tarek. Hussein is a prosthodontist and probably one of the best treatment planners I've ever seen in implant dentistry. His knowledge of radiology, implantology, surgery, and prosthetics is unparalleled. You will get to know him very well. Usually, Dr. Hussein and I tag team at all the courses, and we do these treatment plans. So you'll really get to enjoy him. Right below Hussein is Tyler Sweeney. Tyler is the brains behind the online portal, and he is the COO of the Resnik Implant Institute. So thank you, Tyler, for putting all this together. So we have a lot to go through tonight. So a couple housekeeping items first. We've had a lot of questions about the new textbook. Elsevier just let me know that the textbook should be out by the end of the year. This is the prosthetic textbook. We kind of went a little bit over our page number. We're about 1,500 now. So it'll be about 200 pages larger than any of the other textbooks out there. So it'll be great. Completely a new rewrite. Secondly, first I want to thank everyone for all the great comments on the online lectures. This was quite a feat. I could have never done it without Tyler. So thank you again, Tyler. But we've had a couple questions. I thought I'd address them right at the beginning. The first hands-on skill building session is going to be in March. And we've had a lot of people inquire. There's over 30 some hours of lectures. Does this have to be completed before the skill building? My recommendation is yes. I would like you to be done with all the lectures because this is going to give you a very strong foundation. All the skill building lab sessions we have for you are all dictated on all of this information. It'll make you really have a stronger foundation if you do that. So please, if you can, get those done before March. Secondly, we do have some people who have just signed for the online. Can you still get into this hands-on skill building? We only have about 10 more spots. We've limited because of so many of the procedures that we're going to be performing during these skill building sessions. So if you do want to switch over, make sure you call the girls and do that soon because, like I said, we only have about 10 more spots for that. I believe it's going to be middle of March is the course. And lastly, all of these lectures, if you can't make one of these grand rounds or any of my forums, any of the videos, Tyler set up a resources part on the online portal. Make sure you go to this. This is going to change basically all the time as I add more material. You will see there's supplemental lectures on there, all the course handouts, all the forms, and also we're going to have a lot of videos that we're going to put up that you'll be able to watch. Now, let's get on with the grand rounds. What is our agenda for today? The first part is before we start looking and evaluating treatment planning cases, I'm going to go over a controversial subject or something new in implant dentistry that you can take back to your practice that I want you to be aware of. And this is something that is more significant from last year. So it's something that has just come up that you should know if you're practicing implant dentistry. And then we're going to go right into the treatment planning with Hussein. I believe we have approximately 3 or 4 cases that we've highlighted that we'll go over. We will be done by 8 o'clock. So if everyone does need, we will end by 8. So the first topic we're going to talk about is smoking patient. And I have this lecture, and it's only about 10 slides, Managing the Hidden Risks in Implant Dentistry. Now, why are we talking about smoking? You've probably heard me talk about it overall, probably almost every session that you've been at the Institute and the online lectures. I talk about cigarette smoking, but what has changed is that it has always been a relative contraindication. And now what I'm seeing in the medical legal arena is this is getting very where I'm saying it's in a dangerous level for clinicians. So we're going to have to change how we treat these patients, because it's no longer we can just tell a patient, hey, you need to quit smoking, or I don't want you to smoke a pack a day, a half a pack. Let me tell you the latest that has come out. If we look at, first of all, there's other forms of tobacco use, vaping, cannabis, water pipes. All this is new. And I've really researched a lot of this, and there's been some really good articles out just recently, just in the last part of 2024. If we look at, we all know this, what happens when a patient is smoking? It impairs healing, compromises angiogenesis, it alters osteoblasts, osteoclasts, and we get greater biofilm accumulation on our implants. So at a cellular level, we all know how bad it is. However, what is significant is the latest studies. And this is what I call potential issues for you moving forward as an implantologist. You have to know what the latest studies show. And also, we're going to talk about underreporting and informed consent. If we look at the latest studies, these are 5 systemic review and meta-analysis that were all published in 2024, and they show a significant increase in incision line opening, post-op infection, implant failure, bone graft failure, peri-implant disease. Why is this significant? Because a systemic review and meta-analysis, if you remember, is just not one article. It is an accumulation of hundreds or possibly thousands of articles. So this is very important because now it's coming to fruition. We talked about all these potential issues, but now these studies are really significant. So you have to be ready for that. With that being said, that is the first problem. The second problem is about 10 to 20% of our patients underreport. And what is the definition underreporting? Most of the time, they don't check the box yes because they don't want us to know they're using tobacco, and they put no, or they minimize how much they're smoking. So that's an issue. Number 3, if we look at the latest consensus from the CDC, 2022, they determined about 20% of the US adults still use tobacco. That's 1 in 5. So you have to understand 1 in 5 of the adults come in your practice are going to be using some form of tobacco. So make sure you put that in the back of your mind when you're doing treatment plans and evaluating these patients' medical histories. Problem 4 is when I look at doctors' medical histories, there's a lot of histories I see, they don't even have smoking on it. So patients can't even relate it to you. So I want everyone tomorrow morning, go and see their medical histories. Make sure that you have smoking on your medical history. Also, a lot of patients just have smoking. However, what I've learned, there's other different types of tobacco, vaping, cannabis, water pipe. These are all significant, and we'll go through some of these studies. They can be just as significant as smoking. So tomorrow, make sure you have smoking, but also vaping, cannabis, and the use of water pipes. If we look at studies, everyone thinks vaping is good because there's no nicotine in it. And that can be true, but the majority of vaping e-cigarettes do have nicotine. What is significant about it? It decreases osteoblast growth. So we don't get that bone growth. The osteoblasts are compromised. Also, it reduces alkaline phosphatase, which is an enzyme that is needed for the mineralization of bone. So vaping is bad. If we look at these 2 studies, they looked at peri-implant disease. We see more increase in peri-implant disease in patients who vape. And also, the these two studies specifically talked about the nicotine content. Some of these vaping e-cigarettes have greater nicotine than actual cigarettes. So you have to be, again, very, very careful. Vaping is bad. If we look at cannabis, there's not a lot written about it. This is one article that showed you get decreased bone formation around implants. Also, we're seeing increased marginal bone loss. What does that mean? Patients who are using cannabis on a regular basis, we're seeing more marginal bone loss. So we're seeing more peri-implant disease, which leads to implant failure. So you have to inform the patients of this. And water pipe, which I don't even understand how this thing works, but what I have read about this, it's just as hazardous as cigarette smoking. The studies show decreased bone healing, increases in infection, marginal bone loss, and implant failure. With that being said, I want everyone to look at their consent form tomorrow. Now, you might be using the one from the Institute, which has been updated, which is good. It's still inadequate, and that's why I'm talking about this today. I'm going to have you do something different for these smoking patients. Why is it inadequate? Well, even though the one that we have for the Institute has been changed, but if you look at the older, most common informed consent in implant dentistry, it says this: I understand that extensive smoking, alcohol, and sugar may affect gum healing and may limit success of implants. What's the problem with this? This is informed consent. You are using this basically as your get out of jail card for a patient if something happens. So why would they have extensive? What is extensive? And I just had a legal case where a doctor was sued, and unfortunately we lost on it because of this. He had this consent form, not a good consent form. If you use the one that we have, I reworded it stating any amount of smoking, alcohol, elevated blood sugar may affect gum and bone healing, may limit the success of the implants. However, what I have changed now is this is even inadequate. Why? Because what I have seen in the medical legal arena is that is not good enough. You have a duty, and informed consent has to have risks, benefits, alternative treatments, and financial obligations. Therefore, this consent that we've been using for the last couple of years is good. It's better than the older one, but it's not adequate for you if you're placing implants in smokers. So therefore, what is my recommendation? You need a comprehensive medical history. Make sure that it has all of the smoking and the alternative tobacco products on it. Make sure that you utilized informed consent. We have to educate our patient, and we'll talk about smoking, putting patients on medications and decreasing their smoking here in a minute. So if we look at recommendation 1, you want to make sure all the types of tobacco use are on your medical history. If not, you should be asking the patients and just see, because a lot of the patients aren't telling you this because they don't think that it's necessary. They're thinking that just smoking is bad, but it could be all these other tobacco products. Recommendation 2, this is a separate informed consent that I just made up, and I want you to start utilizing this. It'll be on the online portal. You'll have full access to it. Why is this good and why is this adequate? Well, first of all, I define other than smoking, there's other types of tobacco use: vaping, water pipe, and cannabis. Secondly, I have all the different risks: delayed healing, infection, implant failure, bone loss, peri-implantitis, aesthetic complications. We have all the other alternatives. So a patient can never say, well, I was a smoker. You should have told me the ramifications of smoking. Now I've lost implants and now I need a bone graft. So you've given all the alternatives. So now you don't have a state board problem. And importance of smoking cessation. This number 3, what that does is that explains why you have to quit, and the minimum time that you have to quit. So if you look at the studies, if you remember the studies that we talked about in the courses, you have to quit at least 2 weeks before and up to 8 weeks after. Ideally, they quit forever, but that is the minimum. So, yep, we clearly define that, which is good. We also have in here patients' responsibilities, preoperative, postoperative, and that they have to disclose any changes in their medical history or their smoking habits or whatever. And then lastly, if you look at number 6, it is about finances. And if you read this, if complications arise due to continued smoking, additional treatments or surgeries may be necessary. These treatments may incur additional costs, which will be your responsibility. Therefore, by having that in there, if the patient does smoke, ends up losing the implants, now you have to do a bone graft. Now you're not paying the patient to have the bone graft, they're paying you. And lastly, they're going to sign it and you're going to email this. I always recommend you email this to the patient. Then there is a paper trail and a timestamp. So again, not only do you, when you place an implant in a smoker, do you want to go ahead and utilize that implant treatment or consent form, but also the smoking informed consent form. And as I said, this is on the portal and also on our website. Number 3, document all signs of smoking, whether it is the prosthesis that has maybe some nicotine stain or nicotine on the teeth. This is a great adjunct for it's a get out of jail card. So if the patients don't state that they're smoking, you can't actually prove it. I just went to court on a case. I was defending a dentist. It was a smoking case, and the patient said they never smoke, and that was in their medical history for the medical intake form for the dentist. Where I found that they were smoking was it was a VA hospital. I got their medical records, and in the medical records, buried in the medical records, at the same time that their implant failed, they were being treated at the VA hospital for their excessive smoking. Therefore, what does that tell you? Patients aren't always going to tell you the truth, so document that. Recommendation 4, do not be prescribing patients medication to quit smoking. A lot of these medications, Zyban, Chantix, they have drug interactions with other medications. You don't want to be put in that position. Refer them back to their primary care physician. Let them remove the patient from or get the patient off of smoking. Also, what this does is this leaves a paper trail. So again, if the patient ever says they didn't. So that's recommendation 4. So what do we do to mitigate our risk with smoking patients? Informed consent. When you get those 2 informed consents, that is written. Also in your notes, write that you have verbal informed consent. So document it very well. Be aware of alternative tobacco products because there are so many. And again, do not prescribe medications to the patients, refer them to their physician. With that being said, that was just a quick little synopsis. Again, why I wanted to talk about that is the playing field has changed with smokers, and you don't want to be on the wrong side of the fence if there is a smoking problem. Therefore, let's go right into our CBCT treatment planning. So I'm going to switch my screen off, and Dr. Hussein is going to come on.
Here we go. So the first case for today, Dr. Resnik, is for Dr. Mangifico. Dr. Mangifico, would you mind unmuting yourself, Doc, and maybe telling Dr. Resnik the medical history for your patient for today?
Yeah, can you hear me?
Yes. Hi, Doc. How are you?
Good. How are you? Nice to see you again.
Good to see you. So, Doc, tell me about your patient.
So she's 63-year-old female, and she has a medical record of a knee replacement. So
Okay.
she's pre-med for life. She takes a multivitamin. No other health problems.
Okay,
She's
great,
relatively
great.
healthy.
So what is the problem or what is the chief complaint that we're looking at for this patient?
So I'm not quite sure. I think it was about actually it was a week ago, I think. The crown on number 5 came off,
Okay,
and obviously it's on right there, but we were able to put it back on for the image.
okay,
Um,
okay, great. So the patient came in with an uncemented 5. You put it back in and you took a CT scan. So this is a current CT scan?
yep, I believe it's about a week ago.
Okay, great. So let's take a look. So Hussein, can you give everyone a 360? So we're looking, so you got the crown back on real nice, no problems. And let's go ahead now and look at a pan view and see what we're looking at. Okay, so it looks like there's a periapical lesion there.
Yep.
Yes, sir.
Okay, so with that being said, let's look at a cross section. So you want to make that, there you go. Perfect. Okay. So Christina, you saw this and basically you said this is going to be non-restorable. Is that correct?
Yes, because honestly, there was no tooth structure left. I mean, there was like
Oh,
a little sliver of a tooth, so I didn't think it was restorable. I gave her
okay.
options. She could do RCT, extract, or do a bridge, or do nothing. Take it out and do
Okay.
nothing.
I love it, Christina. You give the patient all the options. It's perfect. I love it. Okay. So with that being said, what Dr. Hussein is doing right now is he's doing a 360 around the center long axis
Mhm.
of that tooth. The reason is if you look at just one cross section, so show them a cross section, Hussein.
Here we go, sir.
Okay. So if you look at the cross section, remember a maxillary bicuspid is what approximately 7 millimeters mesial to distal. So we're looking at this image, which is the thickness of 1 millimeter. So we have to look at the other 6 millimeters. So what he did is he went around the tooth just so we could see the extent of that pathology. With that being said, Christina, now this tooth is non-restorable. So you talked about to the patient about extracting the tooth.
Yeah.
Was this patient interested in immediate placement?
Um, no, she wanted to do whatever I thought was best.
Okay, okay, great. And so so let's look at our options, everyone on the webinar. Our options are to extract the tooth, graft it, or immediate placement. Now, if we look at doing immediate placement, which I would not recommend in this case, Hussein, can you just put an implant in there?
Yes, sir. I planned a 3.5 by 13 millimeter long implant over here, and I got it right now in front of you, Dr. Resnick.
Okay, perfect. So Dr. Hussein put an implant in there at the right trajectory, which would, if you look at, can you show them how you have that going right to the buccal cusp?
Here we go. I
Okay,
could draw a line over here for you, Dr. Resnick.
so you want the buccal cusp of the mandibular arch to go into the central fossa of that prosthesis. So he's going to go right to the buccal cusp. So that is ideally where that implant needs to be. Now, if we look at where that implant placement is, Christine, you have very little host bone, but what I really don't
Right.
like about it is the pathology. So if you look at the apical radiolucency, Hussein, can you highlight that?
Yes, sir. Right away.
So you can see it right there. You're going to have basically a area that has been chronically infected up
Hmm.
against that implant. Therefore, I would say that an immediate implant is definitely contraindicated in this case. Therefore, Christine, let's talk about what would be the ideal treatment plan. So if you remember at the socket grafting course, and
Hmm.
for the doctors in the online portal, I'm sure you've listened to that. There are two common types of extraction sockets, a 4-wall and a 5-wall. Now, a 5-wall would have all the walls present. As you can see, we're not going to have the buccal plate, and we're already missing the apical buccal plate from this infection. Therefore, we have a 4-wall. If we look at our treatment options with a 4-wall, we can do it flapless by doing the ice cream cone technique with the membrane. So hopefully everyone remembers that. Or the second option, which we usually don't commonly do because we have to lay a flap, but to basically flap it. In this case, Christine, I'm going to recommend that you flap it. And the reason is that when you extract that tooth, you're going to lose that buccal bone, okay? The whole tooth's going to come out. And then what you're going to have left is pathology at the apex. And what is significant about that pathology is that that's a periapical lesion, whatever it is, abscess, granuloma, cyst. However, the pH of that area is usually a lot more acidic than normal. So our normal bone pH is about 7.2 to 7.4. This pH is going to be approximating 6. Therefore, Hussein, could you remove the implant and
Here we go, doctors.
and show them with the arrow just the periphery around that? I just want to show right there. Okay. So all that bone is not conducive to growing new bone because it's an acidic environment. So how do we combat that? The best way to do that is to decorticate it, remove all the soft tissue, and then wrap it. Hopefully everyone remembers RAP, regional acceleratory phenomenon, where we decorticate the bone. And what that does is that starts the inflammatory process within the body to bring macrophages and neutrophils to the area to clean that area out. So with that being said, if we go through the procedure for you, Christina, I would do a papilla-sparing incision. I would flap this as minimal as possible so that you can get access to that defect. Remove all of the soft tissue. If you have one of those Lucas 86s, the serrated spoons work very nice, or you can even use a small little round burr. And then go in with a crosscut fissure or a very, very small round burr and decorticate the bone. And then go ahead and graft that area. And what you're going to treat this like is similar to a GBR. So you're going to put a longer acting membrane. So probably I would use a cross-linked or an extended collagen on this because you have to grow a significant amount of bone here. I don't think you will have to use any tent screws. I think you'll be all right with just building this up and using a extended collagen. And so phase one, if for everyone on the webinar, would be to extract the tooth, debride it, decorticate it, graft it. Now, for some of the newer doctors, we like to use mineralized or a combination of mineralized and demineralized allograft. Then we use a resorbable membrane. There are 3 types of collagen membranes. One is collagen tape that resorbs in 10 to 14 days. Regular collagen, which is usually 4 to 6 weeks, or extended collagen, which is up to 16 or 18 weeks. I would state that you should have the longer one. Allow that to heal. And then what I would do is go ahead and take a CT scan approximately 3.5 months after this and see how well the bone has healed. And that will dictate when you can go ahead and place the implant. Okay. Now,
would using a local antibiotic with the bone be
yes,
okay?
that's an excellent point, and I'm glad you reminded me of that. I would use cefazolin in the bone because if there's ever an indication to use it, it would be this one. Just remember, this whole area is compromised. So if you go through this whole process in bone grafting, you want to give that patient the greatest chance at growing enough bone so an implant can be placed.
Mhm.
The only challenge there's going to be with Christina here is um, getting primary closure, because I want you to get primary closure. So what I can do is I'll get Hussein to send me this case, and I'll actually draw you where your release incisions are going to be. So
Okay.
you're going to do a papilla-sparing incision. You'll come straight down the mucogingival junction, but then
Mhm.
you're going to go very broad, very wide. The
Okay.
reason you want to do that is you're going to have to stretch this tissue to get it full closure on it, because when you have a tooth, you don't have tissue there. So we're going to have to extend that facial flap, which I think you'll be able to do. And it's more in the posterior, so that's a lot easier to do than in the anterior. So, but I'll
Mhm.
go ahead and I'll draw that for you, or maybe Hussein can draw it right now so they can.
Oh.
Yes.
Okay,
Here we
so
go.
no, go back, Hussein. Okay, so let's start. Okay, take the blue away. And I
Mm-hmm.
want you to make a straight line down on the long axis, splitting basically the papilla in half. Okay, straight down. Now, hold it right there. Let's say that's at the mucojunctional junction. I want you to go about a 60-degree angle, really out to the anterior. Okay, even a little bit more. Okay, that's good. And then the same, go back on the distal, and you're going to do the same down and now distally, just like that. Perfect. Okay. So the wider the angle, Christina, the greater you're going to be able to bring that flap forward. Does that make sense?
Yeah, absolutely.
And then when you get the flap, just like you did at the course, you're going to hold the flap up with some pickups, and then you're just going to use that 15 blade and
Mhm.
do a periosteal release. So you're going to sever the periosteal fibers. Then you can go in with and do a blunt dissection, and I think it will be you'll have no problem doing that.
Perfect. I have done it on a few of my patients and it works beautifully. And I learned it
Okay.
from the Resnik
Oh,
course.
great,
Yeah,
perfect.
it's
So
it's beautiful.
okay, great. So Christina, what questions do you have that we can answer for you? Does that make
So,
sense?
yeah, so you kind of skipped ahead of me because I was just gonna put the cefazolin in an aura plug, let it heal, and then come back and bone graft. But if I can skip that, that's even better.
Yeah. So let me explain why you could now you could do that. You could definitely do that. However, what if I look at that lesion, it's
Hmm.
basically encapsulated there. So it's
Okay.
not extending into an adjacent bony area. It's basically localized to that area. Therefore, if you decorticate it real well, I think that
Okay.
you'll be able to graft it no problem.
Okay.
Okay.
Yeah.
Now, the only thing I would tell the patient is, because of the infection, there always is a remote chance that you might have to go in and do a secondary graft.
Okay.
So I would always explain that to the patient. To be honest with you, I doubt that will happen, but at
It
least
doesn't hurt.
it doesn't hurt, because if it would happen, then they understand very well.
They're
And
already
if it
ready.
doesn't, then they're very happy. So,
Right.
okay.
Awesome.
What other questions do you have?
No, that's it. My question really was whether I needed to wait for the bone graft, but you
Yeah.
already answered that, so
Yeah, yeah.
perfect.
So, but again, if you have any questions, or if you're right when you're doing it, just let me know. And if you want to go over that incision line again, I can do that for you. So,
Awesome. Thank you. I appreciate it.
okay, Christina, thank you. Okay, Hussein, let's look at patient number 2. Who do we have up?
Yes. Yes, sir. So second patient is for Dr. Jacobs from California. Unfortunately, he wasn't able to make it in for today, but that's our second patient for today, Dr. Resnick. It's a missing tooth at the side of number 5, sir.
Okay, perfect. So first of all, I understand Wednesday night is difficult for a lot of people. So we are going to be doing these webinars every 2 weeks, and we will be recording them, and they will be placed on the online portal. So if you do miss one and you want to watch it, you can always go back onto the portal and watch it. With that being said, so you said a 44-year-old patient. Do we have a medical history on this patient?
Yes, sir, we do. The patient is on lisinopril, and yeah, that's the medication that's been reported. No known drug allergy, but he's a smoker. Dr. Resnick, the doctor mentioned it's limited to social events, sir.
Okay. So let's talk about the medical history. Right off the bat, when I hear limited social events, that scares me a little bit. So uh, you need to discount that. So again, if the patient, my recommendation to everyone is practice safely. If the patient is a former smoker, have them sign a smoking consent form. Just, you never know. I have seen patients that have not smoked for years. They go through a bad experience at a dental office and they start smoking again. So it can happen. Just, you don't want to be on the wrong side of the fence, like I said. Secondly, the patient, no known drug allergies, and the patient's on lisinopril. Was that it
But
for
yes,
hypertension?
sir, that's an
Okay.
affirmative.
Okay. Interesting. So let me put a question out for everyone. That is an antihypertensive. That's an ACE inhibitor. Uh, Question for everyone. Do ACE inhibitors inhibit or do they enhance bone growth around dental implants? Interesting question because a lot of times you'll see this on boards. Antihypertensives at one time were thought to be uh, cause bone loss and not good for integration. However, there's two types of hypertensive medication classifications. One is an ACE inhibitor, like lisinopril is probably the most common, and beta blockers, which propranolol is probably the most common. Both of those um, medication classes actually enhance bone growth around dental implants. So studies have actually shown it helps with osseointegration. So just something interesting, but lisinopril and propranolol are the two. The other ones have been proven not to, they're not detrimental, but they don't enhance bone growth. With that being said, let's go ahead and let's take a look at this. So this is number 5. This is my favorite position if it's your first implant. As I've said in the videos, this area has no vital structures. It usually has plenty of bone, easily seen. It works out really, really nice as your first case. Now, if we look at this, can you blow that up a little bit just so everyone can see?
Here we go, sir.
So is this a male or a female?
He's a male patient, Dr. Resnick.
Okay. Did they give you any information on smile line?
They did report a low smile line for this patient, sir.
Okay. And you said male, correct?
Yes, sir.
Okay. So you might ask, why did I care if the patient has a high smile line, male, female? Number one, aesthetics. If you look at this tooth, can you draw a line showing the vertical bone loss and tissue loss on this, Hussein?
Here we go,
Yeah.
Dr. Resnick.
Okay. So right off the bat, you can see that there's been some vertical bone loss. Now, why is that important? If you remember in the courses and the videos, we talked about an FP1 or an FP2 prosthesis. This is going to be an FP2 prosthesis. If this was in the smile line, if this was in a high smile line, which about 11% of our patients have, then this may be an issue doing an implant, and a fixed partial denture might be a better prosthesis for this. However, male, low smile line, I doubt there's an aesthetic issue to this. I think an FP2 will probably work very well with this. The next thing you want to do is let's look at it from an occlusal view, and let's see if there's been any horizontal bone loss. Okay, so as you can see, maybe Dr. Hussein can draw a line showing there is no horizontal or a very minimal bone loss there. So can you see how that's a straight line? So basically, the patient really hasn't lost much horizontal bone at all. Now, let's go ahead and look in the pan view and see what we have.
Right away, sir.
Okay. Now, go ahead and let's look at a cross section now. So he's going to put up a cross section and we're going to see exactly what we're looking at now. Okay. So is this a previous graft?
It's a post-graft case, yes, sir.
Okay. They didn't tell you what type of graft it was, did they?
No, unfortunately, they did not.
Okay. Okay. So when you see dense bone like that, that leads me to believe that is most likely a xenograft or possibly an alloplast. That's very, very radiopaque. And those two are not as good as an allograft. Allograft, you get more percent of vital live bone, but that still looks like it'll work, but it's going to be a little bit more dense. So there's not going to be as many blood vessels in that area. With that being said, let's go ahead. And for time purposes, do you have a implant? Did you plan an implant here?
I did
Okay.
add an implant, Dr. Resnick. It's a 4.3 by 11, 5 millimeter long implant in that area, sir.
Okay. So you might look at, as I said, Dr. Hussein's an unbelievable treatment planner. Now, go ahead and put put it by a 16 millimeter implant. Let's just raise it. Okay. Now, you might say, why don't we just use a 16? Because it's pretty good bone density there. We don't need to place that long of an implant. So go back to 11 and a half. That's plenty. Now, you will learn throughout the course and just put your cursor right over probably the first 5 millimeters. I just want to show this is where the force is distributed to. Apically to that, very little force goes down to the apex of the implant. Therefore, a 4.3 by 11 and a half is plenty. A 4.3 for bicuspid is an ideal size implant. As I said, normally 7 millimeters mesial distally. So this is perfect placement, perfect um, trajectory. So can you explain what the pink line is or the purple line, and then also what the green line is?
Yes, sir. So the purple line is the patient intraoral scan, Dr. Resnick. We use the iOS scan to fabricate a tooth-supported surgical guide, while the green outline tooth or crown is the wax-up or provisional crown that we designed for this patient to be able to plan our case in a prosthetically driven manner, sir.
Okay. So in the old days, we would actually have to do a wax up. Now it's all done on the computer, and Dr. Hussein is actually really in their company actually owns an AI company, and AI is helping to develop and to design these prostheses now. It's unbelievable. So if you look at that prosthesis that he has right there, if you can see how it's a little bit longer, so it's hyper contoured. So we call that an FP2 prosthesis. As I said, with the low smile line, I don't think this is going to be a problem. So this Dr. Jacobs from California this should be a good case. No problem at all. Now, show them how it's coming out through the occlusal. So that most commonly we like a screw retained prosthesis. So where Dr. Hussein has that, it is perfectly positioned. Now, let me give you another scenario. Dr. Hussein, remove the implant, remove the crown, remove everything. Let's look on it on a lateral view, the 3D image.
Yes, sir.
Now, let me give you another scenario. Let's say that this patient has a high smile line and is very, very aesthetic conscious. Then go ahead and put the pan up. Then and blow that up so everyone can see.
Absolutely, sir. Here we go.
And now draw a line from the mesial to the distal, showing them how we would have to do a vertical bone graft to build the bone up. Yes. So you can see how difficult that would be. So that is a situation, high smile line, that we would have to explain that to the patient, that to grow bone in the vertical plane is very difficult and it's very questionable. Therefore, as I said right from the beginning, in some of these aesthetic cases, a fixed partial denture may be better for the patient. Not in this case. I think this case is straightforward. The other thing I want to show is when you are, after you place the implant, so put the implant in. Okay, now you're ready to take the impression. Now, Dr. Hussein, can you show them the path of insertion, how it would not be ideal because the distal, the cuspid, and the mesial, the second bi, are not parallel. So they're pseudo parallel, but not perfectly parallel. So what you want to do is do a guide plane on the distal of the cuspid and on the mesial of the bicuspid, and that will allow you to have one path of insertion. It'll make the prosthetics a lot, that's it, a lot easier and a lot simpler. If you're ever having, I just had a doctor today call me and he showed me a case where he was having trouble inserting a crown, and it was because of the contact areas. Make them parallel so that you have a long contact area and one path of insertion. Okay, good. Okay, anything else on this case?
I think that's it, Dr. Resnick. The only maybe a note I got with this one is the composite plugs that we've got on this intraoral scan.
Yes, I was going to ask you about that. Are
Uh,
they in ortho?
the patient was an active ortho, but for us to fabricate a surgical guide, we required that the patient would be in passive ortho, so the surgical guide would fit accurately, and we could translate the digital treatment plan into the actual surgery, sir.
Okay, so what Dr. Hussein is saying is this patient, wonder why they left those on, but anyway, if they are in passive ortho, so they're being retained, um, if they're everything ortho is completed, then you can go ahead and finalize everything. Be very, very careful of initiating implant treatment during active ortho treatment. It can be very, very difficult because the teeth may move and the implant may be out of position. So what Dr. Hussein was saying, for them to make a surgical guide, it would have to be in passive ortho where the teeth would not be moving anymore. If not, the surgical guide, which would be a two-supported guide, would not fit and would certainly not be accurate, especially if you're doing a fully guided case. Okay, perfect. Let's go to the last case. We have 12 minutes left, Dr. Hussein,
Yes, sir.
and
Last
show me
patient.
what we have.
So the last patient is from Dr. Simmons from Dallas, Texas, and I'm loading the treatment plan right now for us. Dr. Simmons reported the patient is a 60 years old male patient, Dr. Resnick. The medication he's on right now is Xarelto. And here we go. I'm going to load the plan right ahead for us.
Okay. So, first of all, if you see this software, for some of our newer doctors, this software, which is called Real Guide, Dr. Hussein and his coworkers at ITX is going to show you how to get that on your computers. It's a free software, so you can do these treatment plans yourself. And as I say, it's a great software and it's free. It's ideal. With that being said, you said the patient's post-MI, they're on Xarelta and they're what else
Sleep
was there?
apnea.
Sleep
Patient
apnea.
Yes, sir.
Okay. Okay. So let's talk about sleep apnea. What do we worry about with sleep apnea? If you remember from the medical lecture, sleep apnea, we worry about CPAP machines. CPAP machines put a lot of force on teeth, especially if it's a full arch fixed prosthesis. Also, a lot of sleep apnea patients have undiagnosed hypertension. About 90% of sleep apnea patients are hypertensive. So you always want to check for that. And they were on Xarelto for post-MI. Is that what it was?
Yes, yes, sir. That's correct.
Okay. And so with that being said, Xarelto, if you're not familiar with that, on the newer anticoagulants, it's called a direct acting anticoagulant. It's similar, but it's a lot better than Coumadin or warfarin. The reason it's better is no medications or foods alter it. You don't have to be tested. It works very well. What you have to understand is, though this patient's on Xarelto before any surgery, you have to get medical clearance from the patient's physician, and that patient's physician will most likely alter the patient's medication for this surgery. The reason is these patients will bleed, and if they're going to have that altered. So with that being said, you'll need a medical consult. So let's go ahead. We have, what, 9 minutes left. Let's
9 minutes
see
left.
what we have. Okay, so we have two teeth. They're looking at placing two implants here. We have a little bit of vertical bone loss, not too bad. So the first thing that I look at when we evaluate two edentulous areas is, do we have enough room for two implants? So let's go ahead, and we usually go in the axial view. So I'm going to have him go in the axial view, and he will go ahead and scroll through. And usually I like a measurement at the CEJ, which is going to
We've got
be
15.
15. Okay, that's good. And then also at the apex, just because sometimes you have a dilaceration or a curved root, and you want to make sure that you don't encroach upon the root. Okay,
We've got
so
13 millimeters at the apex, sir.
okay. So in this particular case, you 13 is going to be a little bit tight. So if we're going to put a 4 millimeter implants in, do the math. That would be 8. We want 3 millimeters between the implants. So 8 plus 3 is 11. And then we want 1.5 minimum on each side. So that is 14. Therefore, if you're using a paralleled walled implant, this would not be a good case to place two implants. If you're using a tapered implant system, then you should be all right, because 15 at the CEJ works, 13 at the apex for a tapered implant also works. With that being said, could you show us what you treatment planned?
Yes, sir. So the plan for this patient was adding two implants at the sites number 11 and 12. What I used at number 11 area, Dr. Resnick, was a 3.5 by 13 millimeter long implant. That
Okay,
area.
hold it right there. Hold it, hold it.
Go ahead, sir.
Okay. Now, I want to explain why he placed that implant in that position. First of all, it's in the ideal position with the buccal cusp on the lower, but do you see how he favored the buccal? So when you place an implant, you always want more bone on the buccal than on the lingual. Ideally, 2 millimeters on the buccal, 1 on the lingual. If he would be 1 millimeter on the buccal, then you're more apt to lose that bone and lose the soft tissue. So then it could be an aesthetic issue. So he placed that implant ideally. So there's plenty of bone that's going to maintain what we call the soft tissue drape, which is going to be the aesthetics. Okay, sorry about that. Keep going.
Thank you, sir. So a 3.5 by 13 millimeter long implant over here, Dr. Resnick, at the side of number 11, leaving 3 millimeters in between 11 and 12, 1.5 millimeters to the laminature of the adjacent tooth. And for number 12 area, sir, I'm using a 4.3 by 11.5 millimeter long implant over here, still respecting the same biological factors, leaving 3 millimeters in between and 1.5 millimeters to the laminature of the adjacent tooth, Dr. Resnick.
Okay, so first of all, as you might have heard him say, he stated that he measured to the lamina dura. You always want to measure to the lamina dura. You don't want to measure to the actual tooth root because you want to be 1.5 millimeters from the periodontal ligament. And some periodontal ligaments can be thickened over a millimeter, and that's problematic. So always go by the lamina dura. Secondly, where he placed these, could you go in the sagittal view again?
Absolutely, sir.
Okay. Now, show them if you get the implants too close together. What
Software is going to turn
happens?
red. It turns
So,
red, Dr. Resnick.
so see how that turned red? That means that the implants are too close or in too close proximity that it won't allow you to actually put them that close. So if you get too close to a tooth or implant to implant, that's a problem. Now, the only thing that I did see, I like where your placement is, Dr. Hussein. If we look at from the occlusal view on the 3D image, okay, now you can see how those are coming out at different angles. Can we look at the teeth? Do you have teeth that okay. Okay. So if we go ahead and number 11, if we move that more distally or more lingually, incline it, is that going to affect our trajectory here? Okay. And let's go back and we can play. Okay, that's getting better. So, couple things on this case. So if we were going to splint these, this could possibly be a problem. However, if you're not going to splint them, you could do 2 screw retained prostheses, no problem at all. If you can also bypass the hex, if you would splint them, that just decreases the retention a little bit, but that is another option. But I think you're all right where you're there. That just has to be modified a little bit. But I'll tell you what, I know we only have a couple minutes. What I don't like about this case, let's go back to the panoramic view.
Yes, sir.
Can you take the teeth implants out? This patient has more problems than just this edentulous area. So if you could reach out, maybe even give me this doctor's email so we can talk. What what I see is a lot of problems here. We have active decay. We have periodontal disease. We have probably fractured roots here with these long posts. I this isn't passing the test for just placing 2 implants, meaning I think the last thing this patient needs is these 2 implants. They need a more comprehensive treatment plan. If I look at those lower teeth, there's some attrition there, so the patient probably has some parafunction. It's an irregular occlusal plane. What we look at when we evaluate a tooth is a 5-year prognosis. And if the 5-year prognosis is not good, then we go ahead and extract that tooth if we're going to place an implant next to it. So I just look at these anterior teeth around number 11 and 12. Those don't look very good. And all this decay, they might lose a lot more teeth. So what I would do, I would recommend on this case, Dr. Hussein, this is still in the planning stage, right?
Yes, sir.
Okay. I would not finalize this treatment plan. I would first come up with a comprehensive treatment plan on the remaining dentition, clear up all the disease processes, then come back. I have a strong suspicion that what we just treatment planned probably won't be the definitive treatment plan. I think this patient's going to lose some more teeth here. So that's just my thought on it. But I'll gladly talk to this doctor and discuss that. But
Thank you, Dr. Resnick.
okay, hey, listen, it's 8 o'clock. I never hold anyone afterwards. You've been a great group. Thank you very much. Just so you know, if you do have a case and you want us, we're going to do this every 2 weeks on a Wednesday night. If you have a case, there's no cost. We'll send it over to ITX. Dr. Hussein will do his magic, and we'll go ahead and treatment plan this as a group. So anyway, thank you, everyone. Have a good night's sleep, and we'll see you in 2 weeks. Take care. Thank you, Hussein and Tyler.
Thank you, Dr. Resnick.